We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally, escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Let's take a look at the treatment of choice for specific pathogens. So when the results of cultures come back and the pathogen is MSSA, the drug of choice is either nafcillin, oxacillin, or cefazolin. And they are all have been shown to be superior to vancomycin. So although vancomycin is active against MSSA, these beta-lactams actually eradicate MSSA much faster, and they are considered superior to vancomycin. So the patient should be transitions from vancomycin to a beta-lactam. Ideally, the narrowest possible, so either cefazolin or nafcillin or oxacillin. With MRSA, the drugs of choice are vancomycin or daptomycin. Although ceftaroline has activity against MRSA, it is reserved for salvage therapy. VRE, because it is resistant to vancomycin, vancomycin is no longer an option. So daptomycin or linezolid are considered drugs of choice for VRE bacteremia. And anytime you have a gram-negative Enterobacterialis that's producing ESBL in the blood, a carbapenem is currently considered drug of choice. And that is regardless of if anything else is active against ESBL because of mortality benefit of carbapenems. Other than that, for most gram-negative organisms, you can choose the narrowest agent based on susceptibility results. Now, for oral options for gram-negative bacteremia, high bioavailability is preferred. So here in this chart, you can see dosing recommendation as well as bioavailability. So you can see that in general, oral beta-lactams have low bioavailability. So, again, this is not IV beta-lactam, but oral. So anything that's oral beta-lactam, you get less of it available in the blood. And that is, in part due to limitation of how much we can give oral because of the GI adverse effects. So any higher doses will not be tolerable, whereas we can give higher doses as IV. And also a portion of this will be absorbed. So high bioavailability includes fluoroquinolones, so ciprofloxacin, levofloxacin, moxifloxacin, as well as trimethoprim sulfamethoxazole. So fluoroquinolones and basically trimsulfa are considered high bioavailable.